Welcome to Real Birth Stories. No actors, no scripts, no sensationalism, just real birth stories from my years as a midwife. Every birth is different. Every birth has something to teach us. Every birth is unique. The more birth stories you hear, the more you'll recognize those reassuring patterns of labour, and the more confident you'll become. I'm Kathy Frey, semi-retired senior midwife, maternity author, and founder of MotherWise prenatal education. Let's begin. This first birth story I'm going to be going through with you is, now remember, I'm always going to be looking at my notes, so I'm not always looking at the screen. Great for podcasts, doesn't really matter about webinars. Okay, so this particular woman is what we call a G2P0, so gravida 2, parity 0. Gravida 2 meaning it's her second pregnancy, parity 0 meaning she's never given birth before. So she'd had a previous TOP or termination of pregnancy, or abortion as people would call it. Okay, and there was nothing extraordinary to do with her pre-existing medical conditions or family history, except for the fact that she was Hep B positive. Okay, so that makes a little bit of impact after the baby is born, which I'll explain. All right, so let's just have a little look. Okay, so at 37 weeks and 6 days, remembering that it's absolutely normal to give birth anywhere between 37 and 42 weeks. Prior to 37 weeks is premature baby, that's a preterm labour, and after 42 weeks is a post-date labour. But anything from 37 weeks to 42 weeks is never early or never late. That's a normal 5-week period for women to give birth. Okay, so at 37 weeks and 6 days, I saw her, she was having very minor, I would have seen her a lot more before that as well, but we're just getting around the birth time. So at 37 weeks and 6 days, she had some very minor uterine activity. I was encouraging her to take advantage of optimal positioning along with acupuncture. So that's basically her making sure that she's doing everything she can at her end to make sure that her baby is head down and back to the front. At 38 weeks and 6 days, I saw her again, so that was a week later, and she was in great spirits. She had no particular concerns. Then a week later, at 39 weeks and 6 days, she was having the occasional nocturnal niggle of contractions, but otherwise absolutely zero concerns, good fetal movements, etc. And at that point, we were starting to discuss the plan going forward for the next 2 weeks. Okay, so that at 41 weeks, we would have done a post-dates ultrasound. A couple of days later, we would do a CTG of checking the baby once it's 41 weeks in a couple of days. And then once it's 41 weeks and a few days after that, we would be doing another CTG and potentially talking about doing an induction at 41 weeks and 6 days. However, she goes into spontaneous labour, so that's great. So I saw her at 39 weeks and 6 days. And then the very next day at 8 o'clock in the morning, her partner rang and I spoke to her. She thinks that she may have that her waters may have ruptured at midnight. And there was clear liquor or clear water and just a small amount of it. So quite often, when waters rupture, the head of the baby instantly will lower down, and then that acts like a little bit of a plug. So women sometimes will get a bit of a first gush, which we call the forewaters, and then maybe not so much water after that. That's pretty common. So that's why she was like, I think my waters might have ruptured, but I'm not sure. So she had been having latent contractions since she thinks the waters might have ruptured at midnight. And she was having at 8 o'clock in the morning, she was having 2 contractions every 9 minutes or so. That's what I listened to through the conversation. One was 20 seconds long and one was 40 seconds long. To me, they sounded like mild to moderate contractions. And so, of course, establishing into strong active labor is defined as 3 to 4 contractions every 10 minutes, all over a minute long, that you can't talk through. And typically having done that for an hour or so, an hour or two. Okay, so at 8 o'clock in the morning was then her partner rang, and we said that the plan was that I would home visit her a bit later in the morning, and we'll check out how things are going at that point. So at 11 o'clock in the morning, 3 hours later, I then popped around to see her. And at that point, she was having 3 contractions every 10 minutes. They were about 20 to 50 seconds long. So they were sort of moderate to strong at that point. Fetal heartbeat sounded fantastic, great variability, good baseline. And let's have a look what else I'm reading here. The baby was from a descent point of view, it was D2, LOT, LOP, which means that it was still quite sort of high in the pelvis. It still had quite a lot of descent still to do. And the baby was LOT to LOP, which means the baby's back was on the left lateral, or left transverse, which is a T, or to posterior, LOT, which is left occiput transverse, to LOP, which means left occiput posterior. The occiput is this back of the skull. So we're working out what sign is the back of the skull. What side is that back of the skull on? All right. Next, we decided that we would plan to meet in the early afternoon at the hospital. So this is at 11 o'clock that I've met her at home. She's still not technically in strong active labor, because active labor is 3 to 4 contractions every 10 minutes, all over a minute long. She's not quite there. But I'm thinking, look, probably in 2 or 3 hours from now, she will be, because she had been making some nice progress. And when I checked her at home for a vaginal exam at 11 o'clock, she was about 4 to 5 centimeters dilated of her cervix, which is great. That's how much open it was. But there was still a bit of length to her, about 0.5 centimeter of length. So she was not fully effaced. All right. We're just going to stop the video there. Okay, so now continuing. We're going to call her Jackie, by the way. So Jackie has now arrived at the hospital. And let me just check what time she arrived. She arrived at 1:05 in the afternoon. And at that point, I am going to assess and put down as a record that she established into active labor at about 11:30. Because after I saw her and did the vaginal exam at home at 11 o'clock, quite often when you do a vaginal exam and you sort of give things a little bit of a tweak, that spurs them on into stronger active labor, which sounds like is exactly what happened. So that's awesome. And then by the time that we assessed her in birthing suite, so she arrived at 1:05. I did not need to do a vaginal exam straight away. Like, why would I? There's no particular need. We should only ever be doing that to assess something specific. So I decided that I'd already done the vaginal exam at 11, and it's now 3 hours later at 2:10, and that's where I'm like, okay, I think we'll do another one and we'll see how things are going. Let me just have a look at some of these other notes, because I feel like I might have just skipped through that a little fast. So you just have to bear with me in these stories because I do have to look at all my notes. The clinical notes of the actual birth. All right, so she arrived in at 3:05, and at 3:20, she was on her hands and knees, and she was using the TENS machines, the transcutaneous electrical nerve stimulation machine, which is a really great thing to hire or even potentially buy and use during labor. And I note here that she was coping very well, ! So that's brilliant. At 1:40, we've got some more notes here. Let's have a look. Her contractions are strong, and they had been doing they'd amped up since 11:30, so it's now 1:40. So she's had 2 good hours of really good strong contractions, which is excellent. Baby's still doing well. Contractions are 3 and 10. They're a good 50, almost 60 seconds long. Brilliant. What else have we got there? Okay, so then she started walking around the room. That's great. Mobilizing. Brilliant. Then at 2 o'clock, I note that she's back on hands and knees, coping brilliantly is my word, and she's got a little bit of mild rectal pressure going on. Okay, so often we can hear that when a woman is having her contractions, and there'll be a little bit of a at the end of her contractions, and I'm like, are you getting a little bit of pressure on your bottom? Yes, I am. That's great. That doesn't it indicates to me that she is probably getting close to fully dilated, and certainly that the head is probably lowering down, so that in the pelvis, which is wonderful. Okay, so at 2:10, I did a vaginal exam, and the purpose of the exam, remember there's always got to be a purpose, and the purpose of that exam was to assess progress. All right, because it had been a good 3 hours since I'd done one. And like sometimes women are thinking, well, like if you need to keep doing them more often, don't you? Well, no, you don't, because you're looking at the outward symbols as well, the outward symptoms, I should say, as well. All right, so let's have a look. So at 2:10, oh my goodness, her membranes were bulging! ! So that tells me that if her waters had ruptured previously, it's probably hindwaters, but it doesn't matter at this point anyway. We've got bulging forewaters. That means there's a huge amount of pressure, and those bulging forewaters, this big bubble ahead of the baby's head, can open a cervix just as effectively as the actual head, because it's a firm bubble. But the side effect of having this wonderful forewaters bulging ahead of the baby's head is that it's a really nice cushion for the baby. So babies that have had their waters broken for a long time, with their head sort of ramming into that pelvis, can get a little bit more misshapen in their heads as their head naturally molds to be able to be born. But babies that have forewaters ahead of their head for hours of labor often don't have so much molding, or what we call caput, which is like soft, stretchy, wrinkly skin that's ahead of that head after it's born. So it's a nice thing for the baby. That's why we should never ever rupture membranes intentionally, unless there's a real specific reason to do so. Okay, so the membranes are bulging. The baby is now descended to 9 centimeters dilated. Excellent. fully effaced. The baby's head is a little asynclitic, which means that it's like on a little bit of a tilt. And it's also, what do we got in the, yeah, a little bit of a tilt, and it's reasonably well flexed. It does need to put its chin all the way down to its chest to become very well flexed for actually giving birth. But that will happen. At this point, the baby's 9 centimeters, but it's still -2. So that means it's still, the top of the head is about 2 centimeters above the woman's ischial spines. So that baby still has quite a bit of descent to go. With second and subsequent babies, often that descent doesn't occur until pushing, but typically with first babies, that descent will occur a little bit earlier, but not always. Every birth is a little different. Okay, so we are now, so if we go back to that timeline, I checked her at 11 and at home, and she was sort of 4 or 5 centimeters at that point, and with the cervix still about 0.5 centimeter in length, though she was not fully effaced. But within about half an hour of me doing that vaginal exam, she really did start to rock on into good labor. So that was so 11 o'clock I saw her at home. At 11:30, by 11:30 she was rocking into good labor. At 1 o'clock or just after, we met at the hospital, and at 2:10, her cervix was 9 centimeters dilated, with the baby still a little way up. And so that is fantastic. That means that she was in transition. So when you get to this 8 to 10 centimeters part of the cervical dilatation, or this is what we call labor, right? All of the dilatation is labor. Once the woman is fully dilated, or dilated, people will often say, then that's when she goes into the birth phase. So labor is dilating of the cervix, and birth is pushing out the baby. All right, we're going to stop the video there for a second. So the plan at this point is to basically wait until the woman starts to have what we call an involuntary urge to push. And what I would always say to my woman is, when they're at that sort of 8-9 centimeters dilated, is I don't want them pushing until their cervix is fully dilated, because if she's still got a little bit of cervix there and she starts pushing, it could potentially tear the cervix, and that's a whole little nightmare that we don't want to be going down the track of. So I will be saying to her, I want you to blow through the contractions, and I want you to blow ferociously, like you are trying to move a cloud across the sky. So it'd be like, because you cannot blow and push at the same time. And I'll say to her, when you get to the point where you absolutely cannot not push, let me know. Then we'll do another vaginal exam, and then hopefully you'll be fully dilated and it'll be time to start pushing. So she was 9 centimeters at 2:10. So then the next examination was done at 3:30, and at this point, let me just look at my notes. Right. Okay, so at 3:15, actually, she still had no irresistible urge to push. She was definitely getting an increase in rectal pressure. And so the plan was to reassess her at 3:30 and just see. I've also got a note here that she was very in the zone. Okay, she was basically coping incredibly well. I would always spend a lot of time with my women antenatally, teaching them about meditative labor, which is often called hypnobirthing. But meditative labor is basically where you're going inside yourself. Every time you have a contraction, you're closing in, you're going, ooh, ooh, ooh. And then when the contraction stops, you come out, have a jolly good smile, say some positive comment like, oh my God, that was such a strong contraction. Yay. I mean, we want long, strong, frequent contractions. That's how you're going to give birth. The longer, the stronger, and the more frequent, the better. And so it's about embracing them. It's about letting those contractions wash over you instead of take over you, right? And she was doing an amazing job, and that's where I wrote, she's so in the zone. I love that. Bearing in mind, I haven't looked at these records for years, so it's like me reliving it too. Though I can't honestly tell you I remember this particular client. Like, I did have hundreds and hundreds of births, so but I can feel the moment. I can feel the journey of this woman. Okay, so at 3:30 we did another vaginal exam simply to really reassess. Okay, and she was actually still 9 centimeters. How interesting. But she'd station -1. So she had not dilated more, and that would explain why she's not yet having an irresistible urge to push, because she's not yet fully. And it also explains that until that baby's head really touches the bottom of the pelvic floor, which is when it gets to station 0, that explains why she was not getting that irresistible urge to push yet. So the baby has descended, the baby's coping very well, but she's not quite at 10 centimeters, and the baby's not quite at spines, as we would call it. The baby's a little bit asynclitic at this point. Again, the head's on a little bit of an angle. Just having a look at these other notes. See what else I've got here. 3:30, yeah, 9 centimeters. Okay. Oh, I note here, while I did that vaginal exam, that VE, I also had an accidental ARM, so an accidental artificial rupture of membranes, meaning that my exam popped those membranes. It's pretty hard not to sometimes, but when they're 9 centimeters and the membranes are bulging plus, and you just tap them practically and they'll burst. So the good thing about that is that will definitely bring on the rest of her labor. Yeah, at that point the baby's got a little bit of mild molding, so that's just fabulous. Molding is when the skull plates like overlap each other a little bit. You can feel a ridge down the top of the skull, and that's fine, that's great, that's perfect, that's exactly how it should be with Mother Nature. We've got 0 caput, so we've got 0 spongy bit going on there, and that's because that baby's had a cushion ahead of its head for hours and hours of those bulging membranes. Okay, so the plan at that point is we will do another vaginal exam once she's got an absolute clear irresistible urge to push. All right, so where are we up to? So half an hour later, 4 o'clock. So, okay, those membranes ruptured at 3:30 accidentally because I touched them. And within half an hour, we've got an irresistible urge to push. And I'm just going to pause the video there. Okay, so now it is 4 o'clock. I've done another vaginal exam to confirm that she is fully, and yes, she is. 4 o'clock. Woohoo! Of course, the membranes we know are ruptured. We've got a little bit of molding going on of those skull plates overlapping. Fabulous. That's as it should be. We've got a little bit of caput going on, so a little bit of sponginess on the top of the baby's head. We'd expect that at this point. Her cervix is fully effaced. Her cervix is fully dilated at 10 centimeters. Also, the baby is almost a direct OA position. So that means the baby's head at the front and it's well flexed. We are ready to push. Oh, and it's station 0. There we go. So it's actually, the head is down, descended now to the ischial spines in her pelvis. Brilliant. Our planners, let's commence some active pushing. So we do define the difference between irresistible urge to push of involuntary pushing, where the woman is sort of breathing through her contractions, but she might have a bit of a at the end of them. Now, active pushing means that every time she has a contraction, we want her to take a big breath in and push as hard as she can. And it's like, you want to be pushing in the place as if you're trying to push a poo out. That's the place that you're wanting to push. But often it can take a little while for women to go from all the dilating phase of blowing everything out and letting those contractions go, and then trying to get into the coordinated pattern of actively pushing. So quite often there's a period of, it might be 2 minutes, 20 minutes, where the woman is pushing, but I would define it as uncoordinated or ineffective pushing, because her body has been in labor for a long time, and it's about switching over gears, and that can take a little bit for her body to get into that place. It's not that she's not doing a good job. Her body is adjusting to that new part of childbirth. You know, we always call it labor and birth, and that's why. Labor is dilating the cervix and birth is pushing the baby out. Two completely different stages. So let's have a little look. So at 10 past, so at 4 o'clock we did the exam, she was fully. At 10 past 4 she began some effective pushing, so that's wonderful. And at that point we're listening to the fetal heartbeat in between every pushing. So the pushing stage is really the toughest part on the baby. So whereas when she is just in labor and the cervix is dilating, I would be listening in every 15 to 20 minutes to the fetal heart in a natural normal labor. But once she starts the pushing, I'm going to listen in after every contraction, after every push. I just want to make sure, because we do often hear babies' heart rates decelerate during the pushing, which is absolutely normal and a common thing to occur, and that doesn't faze us so long as the recovery from that decelerated rate is rapid and they return to a lovely normal baseline. So that's all good. So we start listening in after every contraction. So at 25 minutes past 4, we moved it into a left lateral position. So she was on her hands and knees. Oh no, I lie. She was semi-reclined. So she was lying back in the bed. But at 25 past 4, I encouraged her to go onto a left lateral. So that means lying on her left side with her right leg sort of up and her left leg across the bed. And the left lateral is certainly one of my most favorite positions for women to give birth, and especially first timers. And there's 2 particular reasons. One, I don't want her sitting on her bum, because as the baby descends, the tailbone needs to sort of push out of the way as the baby's head comes through, and it's very difficult to push for that to occur when she's sitting on her bum. So we want to get her off her bum. No woman should be giving birth on their bum. Look, if it's a forceps delivery, unfortunately, or a ventouse delivery, if it's an instrumental delivery, it's pretty much impossible for that to be done generally, or particularly forceps, without the woman sitting on her bum. But if it's a natural birth, absolutely get her off her bum. It's a stupid place to be. So if I get her on her side like that, that means that her her coccyx can move out of the way because she's not trying to sit on it. And the other thing is it gives me, as the midwife, a fantastic view of her perineum, because I'm going to be doing everything in my power to prevent a preventable tear, an avoidable tear. And so I know that once we get to the crowning point, I'm going to be asking her to stop actively pushing. I'm going to be asking her to breathe through it. And I want to have a really, really good view of that perineum, because then I have a much better chance of keeping it as intact as possible, or of certainly avoiding a large tear. Okay, so let's have a little look. Right, at 4:40, so remember, if we go back in the timeline, at 4 o'clock we did the vaginal exam, at 4, which found her fully dilated. At 4:10 she started actively pushing. At 4:40 we see we've got BO tick, bowels open tick. Yay! Okay, that means she's pushed out a little bit of poo herself. Look, I'm so excited when I see that, because it tells me that she's pushing in exactly the right position. And it tells me that we've got her head very low, because that head is what's pushed that poo out. Never ever be scared or freaked out about the fact that you might poo when you push out a baby. It's pretty difficult not to, really. Okay, and then 20 minutes later at 5 o'clock, we have vertex peeps. Yay! Okay, so this means, so the vertex is when she pushes and the labia is open, you've got this little peep of the baby's head, and then in between contractions they close up again, and she pushes and you see a little bit of baby's head, and then it closes in between contractions. The vertex is this part of the head right at the top, and that's what we're seeing. And at that point, we can see kind of how much hair it has, what color the hair. Okay, so that is fabulous. So at 5 o'clock, we've got vertex peeps. At 5:15, we've got vertex on show. So that means that when she pushes, we can see some of the head, and in between contractions we can still see some head, and then she pushes and we can see lots of head, and then in between contractions we can still see some head. So the vertex is on show. And then at 5:25, so you remember 4 o'clock fully, and 4:10 actively, effectively pushing, 5 o'clock vertex peeps, 5:15 vertex on show, 5:25 SVD, spontaneous vaginal delivery. We have a birth. Yay! An immediate skin to skin. Fantastic. The placenta was delivered at 3:30. So 5 minutes later, and that was done by controlled cord traction. Basically, this woman had low platelets, so that gave her an increased risk of hemorrhaging after birth. And until that womb is empty and contracted, there is always a risk of hemorrhaging. But with a woman who already has low platelets, we're just not going to mess around. We want that placenta delivered expediently so that her womb can contract, so that we can reduce any chance of uncontrolled bleeding. So I gave her a milligram of syntamitrine, and we had a wonderfully delivered placenta with her fundus then firm and central. The fundus is the top of the womb. It then got a little bit boggy. It loosened up again. 10 minutes later, and so I then gave her some Tocinon to make sure that womb stayed well contracted. Excellent. And let's just see what her blood loss was 350 mils, just over a cup. That's pretty awesome, isn't it? Okay, I'm just going to stop it there. So this baby, a little boy, was born, let's have a look, on its due date. How cute is that? Okay, its ABGAR scores were 9 and 10, which is absolutely fantastic. And because the mother was Hep B positive, we did bathe the baby in chlorhexidine with a chlorhexidine sponge, and we gave the baby Hep B vaccine and Hep B immunoglobulins, just to really make absolutely certain that this little boy was not going to get Hep B from his mum. So that was absolutely wonderful. And actually, because of that, with a woman that is Hep B positive, then we would definitely never use a FSE or a fetal scalp electrode on a baby during labor like that. So the scalp electrodes are the ones that, like a little clip that can go on the baby's head to track its heart rate during the labor. We would never do that with a Hep B pos mum, because then we're opening up the skin and that baby could get infected. So we'd never do that. Okay, so 20 minutes after the baby was born and 15 minutes after the placenta was delivered was time to really do the perineal, or probably a little bit before that. I did a perineal exam and did any suturing that needed to be done. So she had a small what do we have? Okay, so she had a small second degree tear and at the bottom of her vagina, what we call the introitus, and which is like the entrance of the vagina. And then she also had a little tiny tear below the clitoral head, which is actually unusual. You don't see that very often. So I did some continuous locking suturing to the muscle and skin of the second degree tear, which is always a little wee tear, and then I did 2 little interrupted sutures underneath the clitoral helmet. We had great hemostasis, which means really good control of bleeding, and her complete blood loss was about 300 to 350 mils. I formally noted it as 350, but it was kind of somewhere between 300 and 350. And then at 10 past 6, which was when the baby was 35 minutes old, the baby commenced feeding on the left breast, and I checked the placenta. It all appeared healthy and complete. 3 vessels, as it should have. Tidy membrane, so it means they weren't ragged. It was pretty, easy to check. And then half an hour later, the baby commenced on the right breast for a feed. And then at about 7 o'clock, we did the baby's bath of the chlorhexidine sponge and the neonatal exam at about 7:30. And that's when we do the actual weigh and the height and the head circumference and the length, etc. And then at 8:30, she was discharged from the ward. Let's have a look. And there we go. Discharged from birthing suite and onto the postnatal ward. Or in her case, she actually went on to a birth centre. So she left the main sort of tertiary hospital and went on to a beautiful, lovely local private birth centre for a couple of nights stay there. So there we go. That is the story of Jaqui. And how cool was that? And that's the end of this birth story. Bye, everybody. Finally, remember, knowledge replaces fear. The more you learn about labour and birth, the less scared you are. And if there's one thing you don't want, and one emotional you don't want during labour, is fear, because fear produces adrenaline, and adrenaline is like the enemy of oxytocin. So the less fearful you are about labour, the faster you'll dilatate, the quicker you'll birth. So hi, farewell again. I'm Kathy Frey from MotherWise Masterclasses. You can go to www.motherwise.app and join our tribe and become really knowledgeable yourself about labour and birth. Take charge. Don't let it take over you.